Thank you for joining us again on another episode of Dermatology X. I'm really excited to present this talk today because it was inspired by a message from one of our viewers who asked a very interesting question made a very interesting comment rather, that the images in the mycosis fungoides variations talk for hypopigmented mycosis fungoides looked very similar to vitiligo. And indeed, this is a very acute observation. And that was indeed one of the points of that talk, is that the variants of mycosis fungoides or MF can masquerade and mimic a lot of other inflammatory and benign dermatoses. And so it's important to keep a wide differential, to keep MF in the differential, and to consider this and to investigate for this, because if you don't think of it, you won't test for it, essentially. And this can lead to misdiagnosis or for many years. And that led me to look into the literature and find out what has been reported in terms of differentiating between the features of hypopigmented mycosis fungoides and vitiligo. So I hope you enjoyed this presentation. This is part 4 of our series on cutaneous T-cell lymphomas. If you haven't seen part 1 to 3, click like and subscribe to our channel to view the first 3 parts of this video series. So disclaimer, this presentation is for entertainment purposes only and does not constitute medical advice. If you need medical advice, seek health professional help. So this is a slide. On the left-hand side, we have an example of inflammatory vitiligo. On the right-hand side, we have an example of hypopigmented mycosis fungoides. And as you can see, they can present very, very similarly on a clinical level. Vitiligo, and specifically inflammatory vitiligo, can be very difficult to distinguish with hypopigmented MF. They can look similarly clinically, but also their biopsy findings can be similar as well. And this is a quote from a case report, which I'll go through on the next slide. But they comment, the authors comment, when biopsies are taken from the periphery of early vitiligo lesions or from lesions with an inflammatory border, such as in the case of inflammatory vitiligo, a dermal lymphocytic infiltrate, exocytosis, interface dermatitis, and mild spongiosis may be seen, all resembling the findings seen in hypopigmented mycosis fungoides. Very confusing. So this is the paper that I was referring to. It's open access. You can look this up on Google Scholar or PubMed Central. It's online. Check it out. This is the source for a lot of the content in this presentation. It's a very well-written paper. I highly recommend you to go and have a look at it. So this case report describes a case in a 58-year-old female with a 3-year history of white patches. These are hypopigmented patches with scaly raised erythematous borders on the back, abdomen, legs, thighs, and buttocks. It's a wide differentials list for this, including post-inflammatory hypopigmentation, tinea versicolor, pityriasis alba, and less commonly, hypopigmented mycosis fungoides and infections such as leprosy. So what is this inflammatory vitiligo? It's actually a less common variant of vitiligo, often seen as lesions of vitiligo that is surrounded by a raised erythematous border and occurs in less than 5% of vitiligo cases. What's the histology of vitiligo? Well, interestingly, from what I've been reading in the literature, there's slight differences between the histology of typical vitiligo versus inflammatory vitiligo. So with typical vitiligo, generally speaking, the histology is unremarkable, aside from a clear absence of melanocytes. Whereas in inflammatory vitiligo, which is a rarer variant of vitiligo, if you take biopsies from the early depigmented areas or the inflammatory erythematous border around these hypopigmented patches, you see a few changes listed here. So dermolymphocytic infiltrate, predominantly CD8+, but you can also see it with CD4+, so it's a mixed picture. You can see some exocytosis, some interface dermatitis, and some mild spongiosis, okay? Now with mycosis fungoides, again, with classic mycosis fungoides, the features are slightly different to hypopigmented mycosis fungoides. Both tend to show a band-like lymphocytic infiltrate in the papillary dermis with coarse wiry fibrosis. They can both present with epidermotropism as well as Poucher's microabscesses, which are these nests of these atypical lymphocytes in the epidermis. But the immunohistochemistry features may differ. So, whereas in classic MF, you see predominantly CD4+ lymphocytes, whereas in hypopigmented MF, it tends to be predominantly CD8+ as well. And that's similar to inflammatory vitiligo, where you see more CD8+ cells compared to CD4+ cells. So there seems to be quite a lot of overlap between the histological findings of vitiligo and hypopigmented mycosis fungoides. And so there's been some clever people out there who've done a bit of research and compared over case series the features of patients with vitiligo versus those with hypopigmented MF in terms of their histology. And this is a good table that summarizes some of these differences. So in vitiligo, you see total loss of melanocytes, whereas in hypopigmented MF, you see only a partial loss. Vitiligo is more frequently associated with basement membrane thickening, whereas this is very rare in hypopigmented MF. Whereas hypopigmented MF, you see more lymphocytes in the papillary dermis, you see more dermal infiltrate and more dermal wiry fibrosis, whereas these features are less common in vitiligo. It's important to note that these are not absolute diagnostic criteria for each of these conditions. These are just generally speaking, trends and patterns observed when these small case series have been examined in terms of their histology. Now, how do the T-cell gene rearrangement studies compare? So, interestingly, only 50% of patch stage mycosis fungoides lesions demonstrate monoclonality. And monoclonality is also seen in a number of other benign disorders, including inflammatory vitiligo, funnily enough. So it's not a good marker of definitively ruling in mycosis fungoides as a diagnosis. And indeed, in the consensus study, which I discussed in the previous video in part 3 of this series, it was only a minor criteria in terms of diagnostic criteria for MF. So in summary, what are the features which favor vitiligo, inflammatory vitiligo, and what are the features that favor hypopigmented mycosis fungoides? So if your case presents with depigmented areas with an erythematous raised border, if the histology demonstrates a mixture of CD4+ and CD8+, if there's an absence of T-cell clonality, and there's evidence of repigmentation around hair follicles, these are features which point towards inflammatory vitiligo. Whereas if there is overlying erythema and scale over the hypopigmented areas, if there's only a relative decrease of melanocytes and not complete absence, if there's a predominance of CD8+ only cells, if there's evidence of T-cell clonality, and if there's minimal evidence of repigmentation, those are features which support hypopigmented mycosis fungoides. However, please note, these are not definitive features. These are only trends, and both groups will definitely benefit from ongoing follow-up and monitoring, as these features may change over time, and it's important to keep a close eye on these cases. Thank you for joining us on that very interesting tangent in this case series. If you have any more questions out there, please send them my way and I will try to address them to the best of my ability as I can. If you haven't already, subscribe, click like, and I hope to see you on the next video.